What contribution can behavioral science research make to the work of a public health department? I've never defined myself as a behavioral science researcher, but only because I've defined myself as a human factors researcher. Human factors is all about how people interact with systems, and part of that toolbox is behavioral science. Fortunately for me, the system that is public health has always been closely linked with human factors. So let's define public health. Public Health England defined their goals as to protect and improve the nation's health and well-being and reduce health inequalities. That is a broad remit, so I might as well enjoy this and go big and dive straight into national disasters. Let's say that Homer Simpson let out too much nuclear waste and infected a small town. This will be classified as a CBRN event, CBRN standing for chemical, biological, radiological, and nuclear. When events like these occur, the local hospitals can be overwhelmed, so we'll ask for help from the surrounding hospitals, whilst also in constant contact with the police and fire departments. There are big old books of protocols in place for this naturally, but in the heat of the moment, is anyone reading them? Most likely not. In the chaos, where the situation is fluidly changing, people are most likely gravitating towards methods familiar to them and not following protocols that they were taught in a seminar 3 years ago. This extends to the equipment they are using to treat patients. You can develop the best radiation treatment kits in the world and PPE, but if the staff were only taught how to use them once, or even worse, someone put them in the back of a cupboard so no one remembers where they're stored, chances are they'll default to what they're comfortable using. The disparity of work as imagined versus work done can be resolved with behavioral science. The solution in this case is actually currently under development. New tools are being designed that medical staff will be using day to day, but also built into it will be CBRN tools, so the right equipment is already in hand and they'll be comfortable using them. Moving away from life-changing events and at a more intimate level, we could look at the behavioral science to improve the rapport between patients and their GPs. In 2014, doctors were given information on a screen, and the doctors' and patients' eye tracking was recorded. What was found that doctors often spend over 30% of their whole interactions looking at their screen rather than their patients. At the most basic level, telling doctors to keep off their screens and engage with the patients could be a good recommendation, or at least show the patients what they are viewing so they could build a better rapport. The study also noted that less time was spent reading paper records, which may imply that the current screen records might be harder to read. In the paper's own admission, there is still a lot more data to develop. But that's what all good science is all about. Gathering data, analysing it, and making meaningful recommendations, and it is an iterative process. Public health is not at all confined to hospitals and GP surgeries, obviously. It is part of our everyday lives. For some, it's as simple as feeling safe at home, and behavioural science has a key role to play there. In Watford, in the middle of an industrial park, there is an old Victorian house that has been renovated with the idea of being ready to adapt to a dementia-friendly home. Some of the design choices is baked into the architecture, such as this cupboard space that is conveniently ready to be turned into a lift shaft if the person's mobility becomes severely restricted. But other design choices is explicitly linked to behavioural science, such as clear lines of sight and colour-coded paths through the home that help guide people towards each specific room. Increased natural lighting, which is proven to help people stay alert during the day and to sleep better at night. Simple switches and heating controls and safety sensors in high-risk areas such as the kitchen. And finally, homely, simple and familiar interior design to help promote rest and relaxation. Now, these stories are not too dissimilar to my own work within my PhD. I had the novel task of understanding guide running, the sport where a visually impaired person runs with a guide across an environment. To do my research, I had to start from scratch and interview people involved with guide running to understand how they entered the sport, how they performed the task, and compare it to what is known at the time. This identified barriers into the sport, which was previously not known. This process was not too dissimilar to the CBRN researcher who had to map out the links between departments. Both involved a lot of interviews, codings, and conversations, and comparing work as imagined versus work done. To further understand guide running, interviews was not enough, so I had to conduct an observation study with so many bells and whistles. We're talking error analysis, verbal analysis, mental workload scales, and some good old-fashioned interviews for good measure. One of the pretty diagrams I made from it was actually a stupidly large chart that showed how far apart the runners were from each other, what was being said at the time, and their location on the track, with verbal codes developed from it. This is like the GP eye gaze coding, but on steroids. Now you may ask yourself how I'm going to link the dementia house with my guide running work. Well, that dementia house was not developed from nothing. It was built on the distilled information of current research from a specification sheet of what the house should be, in the same way that my PhD ended with a specification sheet so that guide running pairs can use the information to become better runners, along with guidelines how to enter and sustain the sport. Oh, and need I mention that actually my research is public health orientated? Right now, as the UK rises in obesity, it is the disabled population that is being worst affected, as it is recognised that only 11% of the visually impaired population are active once a week. It even has other benefits, such as helping develop other key skills, such as sociability, which is essential for the visually impaired population, as visual impairment can be very isolating. So in other words, my PhD is to protect and improve the nation's health and well-being and reduce health inequalities, but starting with the most vulnerable in my case. Finally, I want to address the elephant in the room, or at least the elephant that is 2 meters away from us and ideally wearing a mask. COVID has been a monumental behavioural science challenge. To convince a whole nation to adjust to new norms and practices is a challenge. All in an age where it's easy to access misinformation. There is a clear need to understand how to shift a culture's behaviour so we can deal with effectively an invisible and intangible threat. This is a battle ideally fought outside of the hospital, because by the time you're dealing it in the hospital, it may have already been too late. Even once COVID is under control, it already has drastically altered the workforce and its expectations. We have normalised working from home, staying indoors, and this may end up having health consequences both mentally and physically. Developing this talk has been interesting, as I've actually had to keep thinking, wait, is this a human factors or a behavioural science problem? Because I've never actually called myself a behavioural scientist, but I think the reality is that it's two sides of the same coin. For example, the NHS has rolled out sending text reminders to patients, and they found the simpler reminder has led to a 25% reduction in missed appointments. From a behavioural scientist perspective, I imagine you may see this as a way of altering behaviours, ideally to stop people forgetting appointments. But from a human factors perspective, we see this as a layer of Swiss cheese in preventing errors of missing the appointment. Just to be clear, the Swiss cheese model is a model we use in human factors. It's an organization's defense against failure, and is modeled as a series of barriers represented by slices of cheese. Basically, if all the cheese holes line up, then someone forgets an appointment or a nuclear explosion happens. Depends what you put the cheese in. And I guess this is what I bring. I bring human factor Swiss cheese, a pinch of Photoshop wizardry, a bit of engineering know-how, and a ton of knowledge about inclusive design, which I think would very much aid your team. Oh, and to answer the question of what contribution can behavioural science research make to the work of a public health department, the answer is simple. Behavioural science is already contributing at every level, and you can't realistically have an effective public health without it. My name is Dr. Victor Jagannathan, and thank you for listening.